Welcome to the first session of Bateman Horne Center's new program, Coffee with a Clinician. This forum is intended for education and connection among patients and clinicians to raise awareness about ME/CFS, long COVID, and other infection-associated chronic conditions. I'm Clayton Powers. I'm a doctor of physical therapy specializing in the care of individuals with complex health conditions. I'm also the education liaison at BHC. Before we begin, I want to thank the generous donors whose support makes our community programs like this possible. For this session, we're taking your questions in the chat that are relevant to the topic we are discussing today. While we can't provide medical advice and may not be able to answer all of the questions during our time today, today's discussion will be an introduction in navigating care for complex conditions like ME/CFS. If you are a patient or caregiver, we recognize that many of you have trouble finding compassionate, effective care. We wish that we could provide care for each one of you, but since we're limited in our capacity, we hope to offer some tips, and we know that this can be a challenging process. If you're a clinician joining, we also hope to give you help in finding ways to offer better care, and recognize that you may want to help patients, but feel inadequate or are unable to do so due to obstacles where you work. So today we have the privilege of being joined by our expert panelists, Dr. Melanie Hoppers, Jennifer Bell, and Dr. Zeest, who each have a unique perspective and expertise to share. Dr. Melanie Hoppers is board certified in internal medicine and pediatrics and is a BHC medical provider. Dr. Hoppers also has family living with ME/CFS. Jennifer Bell is a family nurse practitioner with background in family medicine and women's health and is also a BHC provider. Jennifer has family living with ME/CFS as well. And our guest today is Dr. Zeest, board certified anesthesiologist and host of the podcast Long COVID MD. Dr. Khan is also living with long COVID. So to start, Dr. Khan, let's start with you. You eloquently wrote the first chapter of the Clinical Care Guide and provided an education lecture through our Project Echo program, and it reached hundreds of clinicians on the topic of navigating clinical uncertainty. Can you start by giving us some background on what led you to this messaging?
Sure. Thank you so much, Clayton. It's so great to be here. I'm so happy to join all of you. You know, writing this chapter and teaching through Project Echo on the idea of navigating uncertainty in medical care was really personal to me. My health deteriorated in 2020, and I was ultimately diagnosed with long COVID. But before that diagnosis, I was overwhelmed by the amount of uncertainty in my own health. I didn't have a diagnosis. I didn't have a prognosis. I, for a long time, didn't know what treatments might be available. And that was really scary as a patient. And as a physician, it was really frustrating because in medical training, we're focused on finding really clear answers, solid pathways, clear guidelines to follow. And those answers are unfortunately just not available for conditions like long COVID and ME/CFS yet. So what do we do? A lot of us as patients and a lot of us as providers end up being paralyzed because we don't know what to do, so we don't do anything. And that's not a way that is effective medical care. And there is an alternative. So I wanted to provide a framework for clinicians where we normalize uncertainty instead of being afraid of it. Because the truth of the matter is, none of us have a crystal ball. Uncertainty is part and parcel of the human condition, and that means it is part and parcel of medicine. But it's true that the uncertainty is really profound with long COVID. That doesn't mean that we're powerless. It means that we have to approach care a little bit differently. We have to approach care with curiosity, with humility, and with a sense of collaboration. And this is not new in medicine. We can talk a little bit more about it as we go on, but this is what I do as an anesthesiologist taking care of patients in the emergency room and operating room and these really, really big cases that I specialize in. We don't have the whole picture, and yet we take decisive action and it's effective. So if it's effective in that situation, it can certainly be effective in an outpatient setting and for people with complex conditions. And all three of you know that navigating uncertainty is not magic, it's a clinical skill. So I think once we focus on what we can do and the resources we do have, it compensates a lot for the information we don't know yet and the resources we don't have yet.
Do you feel like any clinician can adopt this mindset or, yeah?
Yeah, absolutely. I'm really passionate about it because I learned how to do it in my residency training. People taught me how to think in a stepwise manner in a dynamic situation. So in the operating room, things change constantly. It's not like I give one medication or put a ventilator on one setting and then just cruise. Although a lot of people think that's what anesthesiologists do. The truth of the matter is it's a dynamic situation and there's no real endpoint until, for me, until the patient goes home. But for all of you and all of us who take care of people with complex illness, it's a long-standing relationship where we can keep asking, what now? What next? And we're not set back by changes because changes in our health are bound to happen, even if the approach is really sound.
Yeah, I love that you highlighted the long-term relationship. I think that from the start, that's one of the most important things that clinicians treating individuals with ME/CFS or complex chronic conditions is that long-term relationship, and establishing there's research showing that it does help the outcomes and helps the person heal. If they have someone they can trust, that's going to reduce stress and reduce the amount of exertion just coming in by knowing they have a safe person that's going to be with them through this process. What are your thoughts about that as far as being a healing effect of the treatment is just the relationship?
A medical visit is a really intimate experience. And that means it's also a pretty sacred experience. That's not something I really fully appreciated. I always have compassion as a physician. I've had a lot of experience with hospital settings on the patient side or the patient advocate side. There's healing in sitting with someone trusted, even if that is to brainstorm, to share experiences, and to share resources. And unfortunately, in part because of the way our healthcare structures are pressured now by productivity and the bottom line, we in medicine have also kind of adopted this culture of as a doctor, going to have a unilateral direction of sharing information. I have expertise that I'm going to give to the patient. And when it comes to long COVID and ME/CFS and other chronic illnesses, both parties, the clinician and the patient, have to readjust their expectations and recognize that just because you don't go away with a prescription for a cure, that this is still a successful interaction, that this can still be a forward step. And that reduces the feeling of failure that a lot of physicians and clinicians experience taking care of people with complex illness, and certainly patients too. So, yeah, I agree with you that trust is vital and that expectation that that intention that we're going to be in this for a while together and we're going to do this together is vital.
I love that. Melanie and Jennifer, the practice of medicine is kind of built on just recognizing symptoms, and they've tried to systematize it in the healthcare system where it's just, let's see you, give you something, and then you're out the door. I've even seen some healthcare systems where there's a sign and it says, in, out, go to the pharmacy. That was easy. Like, we don't really care. We're just here to pass you through the system. How has your experience working with individuals with ME/CFS and long COVID disrupted this framework of in and out?
Completely. I've been practicing for 30 years and mostly in primary care, and certainly have experienced that push to see patients as quickly as possible, be very problem focused, be meet certain criteria by insurance companies in your EMR to make sure you're discussing smoking, hypertension, even if they're just coming in for a knee pain, let's say. And so that is really drilled into the primary care setting, unfortunately. So being at BHC, I've had to really change. I mean, I wouldn't say I changed the way I take care of my patients, because I think I was always that provider who was behind, because I spent more time with my patients, and I always felt it was important to sit down and talk to my patients before I got up to do the physical exam and identify, what might be going on. So it wasn't that big of a change for me to be able to spend time with the patient and recognize the importance of their story. So, but just it's so much on a much bigger scale now. It's a much bigger story. It's a more complex story. And as you were saying, Zeest, that it's constantly changing. It's highly dynamic. And so I think I've had to learn to really do a much better job at that. And also the process while you're talking with a patient and listening to what they're saying, and the art of asking questions is so important. And I think you said something that really caught me, was I'm going to try to remember what it was, but it basically, when you're getting all this information from the patient, you're needing to process that information to try to get it organized, because we know with ME/CFS and long COVID ME/CFS, it's multi-system, it's complex, and what symptom correlates with what diagnosis or comorbidity, and you're constantly sort of in your head moving around trying to think of how this new symptom or worsening symptom could be possibly telling you about their mast cell, or telling you about PEM or something like that. So you're having to really adjust how you think. It's not a linear process how you think when you're talking with patients. And the other thing I think that has been really a humbling thing for me has been resetting expectations, and expectations of myself as a provider. Certainly expectations of what I can ask the patient to do, what can be accomplished in a visit, what can be accomplished in 6 months. The expectations of that I'm not probably going to be able to fix this. And we are really taught to fix things. It's a very linear, point A goes to point B, goes to point C. And at the end, you will have, if you do everything right, the patient does everything right, you will have cure or significant improvement. And that's the way it's going to go. And it's not that way with ME/CFS. It's just not. And that has taken me a number of years to really accept and own. And I still have to work at it. I'd like to hear from what Melanie has to say on that.
So, for sure. I'm like you, Jen. I was always behind. I was always the last one out of the clinic. Always, and I know that the staff would go, "Oh God, it's her today." We know we'll be late. But so I started my own clinic, and I could spend as much time late as I wanted to. And so this wasn't a whole lot different. What is different is, like you said, the we talk about patterns in medicine, and now medicine has become algorithmic. If you have diabetes, here's what we do. 95% of the time, the first drug out of the, your prescription pad is metformin. Okay, so we know that. We know what we're going to do. We know how we're going to handle things. This disease, oh goodness. I remember the first time when I had decided I was going to try to see patients with ME/CFS. And in my ideal world, in my Pollyanna viewpoint, I was going to start with someone very simple and work my way up. And the first patient I saw, I came out of the room and I thought, now how can I leave and not get caught? Or how can I just disappear? Because I have no idea what to do. It was just overwhelming. And I sat there for a minute and then I thought, but there's nowhere else for this person to go. If I feel this way and I'm very passionate about seeing people who have ME/CFS, and I want to run away, what is going to happen to, her if she goes somewhere else? So I just sat there and thought, what can I do? What do I know? No, I don't know why she's having seizures daily, but I do think she has MCAS, and let me do something for that, And so I just started breaking things down into simple pieces. So I don't know if there's any people who are listening who are providers, but remember that being there, like Dr. Khan said, be there. I told somebody yesterday they were going through a really hard time and we were having some problems. And I said, look, at the end of the day, I'm really sorry this is happening to you, and know that I'm here to walk with you. And I heard that from Dr. Khan one day. And I really, that resonated with me. And I just wanted them to know I'm here with you and I'm going to walk with you. And I can help you with your nausea. I can do something for that. I can't fix the reason for the nausea, but I can give you something for that. And I can be there for you. And I know on my end of the spectrum, when my daughter was so, she still is very sick, but when she was in a really, really bad spot, knowing that her doctor was somewhere out there willing to take a call or a message from me is what got me through. It didn't fix her, but it got me through that moment. So just to be there with our patients, to listen to them, to provide help where we can is healing.
Thank you. I love that. I agree that healing comes from knowing you have somebody there for you. A lot of people have had there's a lot of research and patients tell me every single day they've had negative experiences with healthcare providers, and it makes them lose trust in the healthcare system. And often there's more hope when they know that somebody's willing to work with them and be there for them. One thing, as we get into the clinical care side of actually the day-to-day aspect of care, what do you do to allow enough time for patients to express what's going on and things? Because the healthcare system likes to set it up so that the appointments are very short. How do you make it so that you have enough time with each person? Maybe Dr. Khan.
So I can give my 2 cents on the patient end because, I don't have a practice where I see people with long COVID or ME/CFS in a clinic, in a medical setting. But what worked for me is when I broke up my appointments, I worked with the healthcare system to get what I needed. I know as a physician that the appointments are 10 to 15 minutes, that there is one chief complaint that needs to be documented, and that I have many, many issues bothering me. So I changed my approach from coming into the doctor and saying, all of these things are happening. What do I do to fix all of it? And instead, I worked with the system. The system is not perfect, but I was working with it to try to get what I needed. So I took a little time myself. I, have some trusted people in my life who I did this brainstorming with and preparing with, because we know that there's cognitive issues that come along with these disease processes. I certainly had them. What is bothering me most right now? And what do I need help with in managing. And so I would dedicate an appointment to one or two issues. This is what's bothering me. I'd say to my doctor, this is what makes it worse. This is what tends to make it better. I can't figure out what else to do. Do you have any ideas? That's an invitation for a brainstorming session. And that's also coming into the visit with some data and sort of setting up your provider for success. It's not our job as patients to make our doctors feel good. That's not what I am trying to say. Although a lot of us have to put on an act to try to get care. But it really helps the brainstorm session. It helps the problem solving when both parties collaborate on it. So I know as a physician that I'm going to ask a set of questions when someone comes to me with a problem. I know that I have time constraints. And so I made a lot of short visits dedicated to one or two issues, and that helped.
That's super helpful. Do you find that going in with a diagnosis of long COVID or ME/CFS, is that helpful, or is it more helpful to kind of have a priority list of issues that you're dealing with that you want help with?
Yeah, I think what I did, I had a great primary care doctor who recently left the system, but we did a couple of things. Everybody has typically, with your health insurance here in the US, an hour dedicated for an annual physical exam. And I took advantage of that to go over the big picture. And then, Clayton, I'm sorry, I'm like forgetting exactly what the question was. It's like, coming in with the long COVID diagnosis or the ME/CFS diagnosis. So that's already established. And then I'd come in with a specific symptom, because the unfortunate truth is we're doing a lot of symptom management in the treatment of these complex illnesses. And that is okay, because it often works. And if my goal is to function better, and that means I'm treating symptoms, that's okay. If it's effective, it's okay. So I would come in not saying my long COVID is causing elbow pain. I'd come in saying I have elbow pain. It gets worse when I'm doing this. It gets better when I'm doing this. It's been going on for this long. Kind of like who, what, where, when. And then start collaborating on what can we do about this.
That's super helpful. Thank you. And if someone feels, for Melanie, if someone feels that they aren't receiving effective, compassionate care, do you have any advice for what they could do to try to navigate that? Because it is really hard to find providers. I hear this all the time, is I am trying to find a provider who will listen to me. Any suggestions for that?
Yeah, so a couple things I'm going to say here. So one thing that I would advise, I love that using the annual health visit. That's a great idea, to go in and get the generalities. Here's I think I have ME/CFS, or I know I have ME/CFS, long COVID, I know it, whatever. But you can get that established, maybe share the clinical care guide and some things like that to kind of get things started. Additionally, it's something I think would be really helpful, because, and this is what I do. Yeah. And this is what I do with my daughter. Okay. I'm on both sides of the aisle, and I understand both sides of the aisle. I understand that I have a clinic, and I have nurse practitioners in the clinic who are seeing patients. And if they spent 2 hours per patient, there wouldn't be a clinic. So we can't do that. On the other hand, I know what it's like to be a patient and need to have 2 hours. And it's constant cognitive dissonance, because, what do you do? What do you do? So one thing is, I would suggest that everybody on this phone call start a list, if you don't already have it. you can make a document of all your medications. You know, it doesn't have to be done today. You can add a medicine a day, add, you know, whatever, do it slowly. I know you have to pace, but try to have a list of your medications and why you're on each medications, because I can tell you it's going to confuse some people, some of the things you're on, you know. So you need to know what you're on and why you're on it, or at least have it written down so that you can share that. Because if you start going, gosh, it's that pink pill, well, now you've spent 30 seconds trying to figure out a pill when you could have spent that time talking to the provider. A list of the things you know you have. If you know you have ME/CFS, if you know you have POTS, if you know you have orthostatic hypotension, whatever, list your diagnosis that you know you have and what you're on for that. So kind of have some prep information that they can keep so that you can, you know, you have your copy at home. Here's the copy for you. So when you leave, they're not spending all this time documenting all of it. It kind of gives them a tool to go back and reference and look at. What are your top 2 issues, and talk about those things. And just as Dr. Khan said, you know, and I think you said this, but, you know, here's my symptom, here's what makes it worse, here's what makes it better. Write it down, because if you try to remember in the moment, you know how that goes. I mean, I never remember everything, and I don't have, you know, brain fog. Maybe I do, but, you know, I'm not the patient. I've got all the information. I'm still forgetting half of the things I meant to do. So take notes, start way ahead of time. I don't want you to do this the day before and crash when you're going into your appointment, but take notes and kind of work on these things. Start now for your next appointment. Rest before your appointment. I don't even know what the question was either, and I'm just going off on a tangent, but here's some
No, you're
things.
great.
You know, rest before your appointment. Make it at a time of day when it's conducive to you. You know I do not make appointments early in the morning for my daughter. It is it's hell to try to get there. We can't do it. So it needs to be, I try to get the last appointment if possible, because again, I know now the person who's seeing us has not got 5 people behind us that they know they're getting chest pain over the fact that they know there's 5 more people waiting behind and they're getting behind. So if you're the last one, you know, hopefully that's helpful. Try to think of any other things like that. And be vocal. You know, if you need to lie down, say so, or just do it. You know, get on the table and lie down. You don't have to have permission. If I go in a room, somebody's laying down, I'm not offended. It's fine. You know, be comfortable. Tell the person, hey, my legs are hanging. I'm going to need to lie down, not just sit here, you know, or what have you. So don't be afraid to ask for accommodations. You know, ask for those things when you go in. So I don't know if I answered your question.
Those are great tips. No, those are great tips. I think really it's about how do we, especially as individuals go in to seek healthcare, how do we get care? And then what are the options for accommodating the visit? I know when I have patients come in, I say, if you want to lay down, please lay down or put your legs up. Like, we'll dim the lights and try to make the environment less stressful, less paperwork and questions and things. Jennifer, do you have any other tips or strategies that individuals can use to help make it a more effective visit while also conserving energy?
Yeah, and I think Zeest and Melanie have done a great job at sort of talking about what patients can do, and I'll come at it more from the provider perspective. You know, I know as a provider, especially in a primary care setting, if you have somebody come in with a really long list of concerns, things start shutting down in your brain. And I hate to admit that happens, but it does. So I would try to encourage patients when they had a lot of concerns, you know, to pick the top 3 concerns, you know, and I find that actually encompasses a lot, particularly even in ME/CFS patients. The top 3 concerns, I think, can sometimes grab a more global perspective of what might be going on with them. That certainly, I think, from a provider perspective, feels more manageable than literally a list of 20 things. So doesn't mean you don't have that list, but it means that you prioritize that list. Okay. So And as a provider, I think it's really important to recognize that there are 20 things on that list and that you need to address each of those. And you're not going to be able to do it in a 15-minute visit. So there are a couple of strategies. One, have them come back in a week, 2 weeks. Try to utilize telehealth if you can. I know that telehealth is starting to be they're being more stringent on who qualifies for telehealth, which is really, really, really unfortunate. But we have to go work within the reality that we have. But try to ask for telehealth if you can. Try to be prepared as much as your brain fog will let you and your stamina will let you to be prepared so that you have an understanding of what you need to talk about. As a provider, I also think it's really important when you know you have a patient who's complex that you talk with your clinic that you work in, the management of your clinic, say, I need 30 minutes with this patient. You've got to give me more time. So I think as providers, we need to have the ability to have the voice to ask for some change and accommodation for our care of you. And so I would really encourage providers to do that. And that may be naive on my part. It's been a little while since I've been in primary care, so it may have changed a little bit, but I really encourage that. I think one of the biggest challenges as I think about our efforts at BHC to get as many primary care providers involved as possible in caring for ME/CFS patients is that we know how complex this illness is. We know that when you come in saying that you're having increased pain, it's not necessarily arthritic pain. It's not necessarily, a nerve impingement. It has to do with your bad sleep. It has to do with your orthostatic intolerance. It has to do with your mast cell activation. And it has to do with the fact that you're in post-exertional malaise. And so it's not when you're focusing on that complaint of pain, as a provider, you need to be thinking beyond the very black and white issues of that in a primary care setting we often focus on, which is joint, nerve, muscle pain. Where does it fall? Inflammation. And we kind of have this process we go through to try to determine the diagnosis. But thinking beyond the typical and going, is this person in post-exertional malaise? Is this person not sleeping and that's why their pain's really flared? And so you have to try to, as quickly as you can in that setting, assess those things so that you can apply an effective treatment approach. And that one still sort of, that's the reality of caring for people with ME/CFS that we still need to, I think, really acknowledge and talk about, because it's going to be hard in a 15-minute setting. It's just going to be hard. But does it mean you shouldn't try? No, it means you should try. And all these things we've talked about here today, I think are really important. And being as organized, keeping a journal of your symptoms, understanding your symptoms, understanding the way you present, even if you don't have a diagnosis, even if you don't know, if you can, start creating some kind of journal so you can start making sense of your symptoms. And that will really, that is a partnership that you have to have with your provider, it is a partnership. And I can't do my job without you. And because you are going to inform me of so much and you are going to help me help you. So I'm just going to really encourage to try not to feel really discouraged if you don't already have that diagnosis. Go on our website. We've got tons of information. You can do a little self-diagnosis if you need to. It at least is going to provide you some direction.
That's super helpful. Dr. Khan, if somebody's been trying to kind of use these strategies already and they are struggling to still get effective care or compassionate care, do you ever suggest going out of state or trying to find, maybe not going out of state, but try to find a provider that can take that extra time and is willing to, and just kind of, because it's hard if you just go through the traditional healthcare system and set up a ton of appointments, it can be really hard. So, and sometimes it's impossible to get into those appointments or to get the option of telehealth. So what other ways can people navigate this? tough situation?
That's a fantastic question and a reality that almost every patient faces. There's a few issues or possibilities that come into play here. One is your doctor's personality doesn't suit your needs. Uh, Clinicians are humans too, and there are nice people and there are not so nice people. Some clinicians approach, I'll talk about long COVID in particular, with they think they know the answer, and maybe you're not jiving with that answer. They have a perspective and they have a set of beliefs associated with this diagnosis. And then there is the practical matter. Like, I like my provider, but this clinic setup is not working. These visits are exhausting me. The system is not working for me. And so that latter part might be potentially the easiest, or at least the one you want to spend more effort in. You like your provider, you have a good relationship, it's successful, it's effective, but it comes at a really big cost to you and it's not necessarily sustainable. That would be a good situation, as Jennifer was saying, in using your voice as a patient to communicate that with your doctor. Because what happens is, I think in general, we as patients come in with a set of intentions and needs. The provider comes in with their concerns and their documentation. And it's amazing that two people sitting in the same room can still be in echo chambers and not be talking to one another. So use your voice both for patients and providers. Let your provider know this is difficult for me. This is a concern, whatever that is. As a provider, it's important to say, I hear you. This might be a little tangential, but I hear your main concerns. I'm also going to order this thing that might seem random to you, but I'm worried about, say, your risk for heart disease, even if you're not seeing any of those signs. So I want to make sure that I don't miss something, and that's why I'm ordering this. This communication is key. In the first example that I gave, where let's just say your doctor's a jerk, and you weren't treated well in your visit, what I have recommended on my podcast and in my writing multiple times is I take a deep breath, I let them finish their sentence, I say, okay, and then I leave. Because we all sort of recognize when we're talking to a brick wall. And you have to decide, even though this might be unjust and it took you a lot of effort to get there, that maybe this is a dead end and you've got to pivot and you've got to move in a different direction. So I've walked into specialist appointments that took me so much effort to get into. And within 30 seconds, the doctor didn't look me in the eye and started talking about some conspiracy theories. And I took a deep breath and then I left. And I didn't make a follow-up appointment. There are also times where I have taken the extra step afterwards and messaged the doctor and said, I'm not seeing you again because of X, Y, and Z. And I recommend you look at X, Y, and Z. Always polite. And you can also, if you're really treated poorly, like escalate that to the administrative staff. We have a huge healthcare structure because we have so many administrative people. So that also means there are eyes on your doctor, and it's not anymore, for good and bad, a lot of private practices or solo practices. So you have some options. But ultimately, you need to do what is best for you and most effective for you and the best use of your energy. So, kind of convoluted answer to a few different possibilities.
No, that's helpful. And I'll put a plug in for occupational therapists. I know physical therapists, I'm trying to change this, but we have a bad reputation in the physical therapy world of helping patients because we've been pushing as a profession. We love exercise, we study exercise so much. And so there's this push to exercise fixes everything. And I'm trying to educate physical therapists on how to approach care that doesn't emphasize graded exercise and is more helping approach things. And so that's one push to therapists or rehab providers. Typically, we have a little bit more time with patients. We typically get 30 minutes to an hour or longer. So I get an hour with each person. And a lot of patients have said that that has helped them in between their visits with their doctors as we work together. But a typical physical therapist is not generally going to, will most likely cause more harm than good. And so it is hard to find and navigate that as well. But Melanie, do you find sharing the resources from Bateman Horne Center or other resources to providers, is that helpful? Or how do you go about it? Because I've gotten backlash when I've tried to share to a medical provider, here's some resources to help you improve care. I've gotten some backlash.
Yeah, and let me acknowledge something I saw over here in the chat. Somebody expressed a bit of dismay as to having to manage their providers. I get it. I agree. And it makes me want to cry and scream at the same time. But what we're trying to do today is give you some hacks so that at the end result is you have success. Yes, we see all the glaring problems with healthcare. So please understand, we're not suggesting that this is the ideal situation. Anyway, so I do, and I know it's so different for me because I'm a physician, right? I go in and I go, hey, here's this. And of course, they're going to politely take it. But I'll tell you, as a physician who has received things, I'm sure sometimes it has caught me off guard. I'm like, oh, okay. And I may not express anything. I may not express appropriately. Oh, this looks great. I try to, but I'm sure there's been times when I've taken something I might have looked bewildered. I save it. And when the question comes up, I often refer back to it, right? Like at my clinic, I took the clinician care guide and I gave it to everybody and they all politely said, thank you. And I was like, yeah, you're going to throw that in the corner as soon as I walk out the door. But when they have a question, because I've also sent them people with CFS and said, I need you to take care of this person. And I know that they're going to pull that back out and go, okay, I need to look at this. So a lot of times I use the source when, I have this resource that I am a part of that will discuss all these different topics. And sometimes I'm like, I don't need that. I don't do that. And then the next day a patient will come in with that. And I go back and find that source and look at it. So I do think it's helpful to share. I think taking the QR code or the clinician care guide, if you have a hard copy to give it to them, great. Again, just to say, hey, here's some of the latest information. So you're not implying that they're dumb or you're not implying that they're uninformed, although they very well may be. But, here's some of the latest information. I read a lot of this. I think it's really helpful. If somebody's offended by that, they're probably, I don't know, that point where you start looking like Zeest talked about, maybe where you are. Because, the worst doctor is one that's not curious. If there's oftentimes I go, I'm not sure. Let me go read about that. I have no problem telling you I don't know the answer to that question, but I will go read and ask some friends I'm going to call a friend and see, Jen, what do you do? And we'll talk this through because between us, maybe we have somebody, but yeah.
That curiosity, I was actually going to bring that up. So thanks for queuing me up, Melanie. That's one of the things that I'm discouraged about, is so many patients come to me and say, either they went to the emergency room or they went to see a cardiologist or their primary care. And they were like, well, we don't, I think it particularly happens in the emergency room where, well, we don't know what's wrong with you, and often get a diagnosis of anxiety or functional neurologic disorder or something like that. And I recognize there are limitations within ER settings as to what they can and can't do. But it's like, you have somebody who comes to you with a complex set of symptoms that don't make sense, give that person the benefit of doubt that it's not just all in their head. And I hate that term, but this is something real, and we need, and if you don't know, be willing to own up to the fact that you don't know, and then take it that next step further and try to learn and understand. I mean, we all know about long COVID in the medical community, and I know there are a lot of physicians and nurse practitioners and PAs and nurses that don't agree with or don't think long COVID is real, and so that's challenging. But I guess I'm any clinicians on the call here, I challenge you to be curious. I challenge you to recognize that maybe you don't understand something, but there are answers out there. And there are a lot on our website. There's a lot of available information to learn about it. And so to me, it's not really, you don't have the luxury of saying, well, I don't know how to treat long COVID. Well, actually, there's a lot of information out there now. Mm-hmm. So I guess I would just implore that.
I would also add that if you are someone who has learned something, if you're a clinician or a provider who's learned something about long COVID, to talk about it. Tell 5 of your colleagues, and then start keeping a Rolodex in your mind. I love, what I miss most about practicing medicine in a hospital is the doctor's lounge or the staff lounge, because you learn so much and you get to collaborate in ways that, as an anesthesiologist working in an operating room, I don't get the opportunity to as frequently. If you learn something about long COVID that is effective, or you have a new patient who's coming with a condition that is new to you, use your brain trust, learn from them, and then give back, so that the word is spread that somebody in your institution knows about this, has seen this before. You're not the only one. A lot of us as professionals don't want to admit we don't know something, and it really helps to remember, oh, I don't know, but I remember Sally was talking about this about one of her patients, and you can ping them. Just as we're talking about a collaborative approach between provider and patient, I think it's very, very important for providers to collaborate with one another. Clayton, you're talking about occupational therapy. I have ordered PT, OT to bedside so many times, but it's been in the ICU. I am learning just how valuable occupational therapists are, about how many resources there are in the healthcare setting. And I think that a lot of doctors in particular may not recognize that there is all of these resources. So again, be curious, as all of us have said, and ask yourself, what can I offer this person? What can I do? This can be a prescription. It could also be disability accommodations. Something as seemingly simple as a disability placard for a car can be the difference between somebody being able to get out of their house or not. Accommodations for work, and then brainstorming. We were talking, I think, Jennifer, you were talking about, alluding to this too, where you want to bring, as a patient, 1 or 2 ideas. As the provider, your opportunity could be helping to clarify, what are these top issues? We need to expand our approach as clinicians, expand our approach from thinking the answer is in a prescription pad or in an order form, and as patients to modify our approach and say, I need someone who can brainstorm with me, plan with me, and is willing to try different things and move forward. We talked a little bit about this idea of pivoting. Melanie and I kind of together came up with this phrase of, I kept telling myself, I'm doing trial and error to get better. I remember telling my husband, this is the most inefficient way to treat a big life-changing disease. And what I realized later was that it's really not trial and error, it's trial and pivot. If you are using I want to say logic or like a rational approach to care and saying, we don't know what the ultimate answer is. Let's identify what is bothering you most. Let's together assess what are the costs of each type of treatment. Cost could be not only financial, but I don't think about side effects anymore. Every medication is going to give you a side effect. I think about that in terms of the cost to me. Is this treatment valuable to me? What's my line in the sand for stopping and moving away from this? Clinicians cannot be pressured into prescribing treatments that they are not comfortable with or that have not been sort of really established. And patients cannot be demonized for saying, I'm not willing to try this for X, Y, and Z reasons. I'm not willing to continue with this because the cost is too high. And so those types of approaches really help clarify and bring some structure to a very complex, interconnected pathology. And that way you start making progress. And it's really frustrating to say it's one step at a time, because a lot of times it's a couple of steps backward. But we want the approach to be sound, even if the treatments are not all proven.
Great. Do you find, is it more helpful for someone to say, these are my top 3, and let's say the examples are lightheadedness, fatigue, and brain fog? Or do you find it more helpful for them to say, my top 3 are, I'm having trouble showering, or getting ready for the day, like I can't tolerate that, or I can't make a meal for myself, or some of those more functional things when they bring that up with their providers?
I'd be interested to hear what Melanie and Jennifer have to say. I personally think it's whatever is bothering you.
They're really helpful. I think if you maybe to provide those as examples of how do I know what does fatigue feel like for me? You know, fatigue is such a big word with so much baggage that comes with it, and also so different. I mean, there's not just one type of fatigue. So identifying, like, my fatigue is so significant, I literally cannot lift my body off the couch. I have patients describe it as a panini press, or too much gravity in the room, and that is very different than being tired after a long day of work necessarily. It's a different type of fatigue. It's a different than depression fatigue. So I think when you have those 3 primary complaints, be specific, concise, specific as to what do you mean by brain fog? What do you mean by fatigue? What do you mean by lightheadedness? For example, I can't shower. And I think that can really help organize that. Melanie, you have any other thoughts?
Agree. Specific is very, very helpful. If you say I'm fatigued, well, if you have a clinic full of patients and half of them coming in say they have fatigue, and they're not people with ME/CFS, their idea of fatigue and what that provider's used to hearing is not what you were experiencing. I was just sitting here thinking, I wonder if, I believe Good Day, Bad Day questionnaire is in the clinical guide. I not too long ago, I had this nurse practitioner that I send my patients to that, or people to, that I think, she will see people with ME/CFS, and I feel good about her seeing them. So I sent her a patient the other day, and she was really busy, and I was telling her, and she emailed me back and said, this is what I got. She said that here's an email. She sent me like a 10-page email. So I was like, okay. She's like, okay, you're going to help. So anyway, I went through it, and I went back and I asked her, I said, what are some of the things that would be helpful to you? Because I know she's so willing to see the patient, but I know that she's like, oh boy, I just doubled my work for the day or whatever. So trying to help. Tell me how the patient can help you so that so I can send you 3 patients a day and not just 1. So I'm trying to maximize a good provider. And one of the things she said was, do you have questionnaires that you have patients fill out that would help with some of these symptoms? And so I was just thinking a good day, bad day questionnaire could be really helpful, because when I get that questionnaire, it is a picture. It paints me a picture of this patient, because sometimes I'll read the symptoms list. I'm like, oh, they don't sound too bad. And then, they don't sound like they're having too hard of a time. And then I get the good day, bad day questionnaire, and they say I have 28 bad days. And on my good days, I'm up 2 hours. I'm like, oh, okay. We have a whole different situation. So I think sometimes that could be helpful, because I think clinicians who don't only see people with ME/CFS really grapple with understanding the severity of the illness. And so you really have to paint the picture. And if you use the same words that other people use, it's not painting the picture. You need specifics. So I really like that specific recommendation.
Excellent points.
I know we just have a couple minutes. That good day, bad day questionnaire is so enlightening. It's available on our website. I'm hoping somebody, I think Talia just put the link in. Fill it out. It is very, very enlightening. And don't be afraid to really describe how bad is a bad day. And, use it as a way to really describe your function. It's not just about fatigue. It's how you function physically, cognitively, emotionally, socially. It really provides an enormous amount of information and paints a really accurate picture.
Thank you. Dr. Khan, any final thoughts about the clinical care guide and this navigating clinical uncertainty that you hope people take away?
Well, I'm also reading in the chat how it is really frustrating to feel like the onus is on you as a patient, and like, do you really expect patients to have to rearrange their whole life around medical appointments? I wish the answer was no, but this is a tremendous project that you are now on. Someone used the term project manager. It is kind of like that. Stay hopeful. I think that the way to reframe this approach is that you are doing what you can while answers are being elucidated by science. This is a very challenging time across the board, you could say, in any sort of arena. For us personally, who are struggling with illness, it is important not only to have someone to collaborate with who's a medical professional, but also someone to collaborate with to help you do that brainstorming, because that is a cognitive drain as well. This is a big project. This is a multifactorial project. This journey might take longer than you would like, but please remain hopeful and focus, again, the same advice that I give to clinicians. Focus on what you can do instead of what is not available yet. There is grief in that. This is not dismissing that. But what I recommend to clinicians and what I recommend to patients is that we not allow the grief or the overwhelm to prevent us from taking effective steps. I'm sorry that we're all here, but there is hope, and I know it's hard.
Thank you. Thank you for sharing, and thank you all for joining us today. We wish we could provide care and help each one of you, and we hope that this is a helpful kind of discussion and gives you some ideas or tips and tricks for navigating this really painful and traumatic process. And we hope to see you again for our next session on Wednesday, November 12th at 10 a.m. In the meantime, please watch for our email with the recording of today's session. And thank you, and have a great rest of your day.